3 of the 5 medications I'm about to share with you require no prescription. You can walk into any pharmacy right now and buy them off the shelf. That is exactly what makes them so dangerous for anyone over 70. Because when something is easy to get, we stop treating it like a drug. We treat it like it's harmless. And for a body that has crossed the threshold of 70, that assumption can mean the difference between independence and a hospital bed. Here is something most doctors don't explain clearly enough during a 15-minute appointment. The human body processes medications in a fundamentally different way after 70. Your kidneys filter drugs out of your bloodstream more slowly. Your liver metabolizes compounds at a fraction of the rate it managed 20 years ago. Your brain becomes dramatically more sensitive to sedatives and anticholinergic compounds. A dose that was safe for you at 55 can now cause falls, memory impairment, kidney stress, and cognitive decline that gets mistaken for early Alzheimer's. Today, I'm covering 5 specific types of medications that illustrate this problem more clearly than any others. All 5 appear on the American Geriatric Society's Beers criteria, the medically reviewed and regularly updated list of drugs considered potentially inappropriate for older adults. This isn't fringe advice. It is mainstream geriatrics. My name is Dr. Adrian Cole. I've been practicing for over 20 years, and this channel is dedicated to translating medical research into simple, practical guidance for adults over 60. Now, let's go through these 5 medications, and more importantly, what to do if you or someone you love is currently taking any of them. There are 5 types of medications I personally approach with extreme caution in patients over 70. I want to be clear before we begin. This is not about alarm. This is about awareness. Many of the people currently taking these medications were prescribed them years ago when the risks were less understood or when their body was in a different place. Some were never warned. Some were warned once and forgot. And some are taking medications that were never meant to be taken long-term at all. What I want to give you today is information. Because informed patients and informed families make better decisions than confused ones. Let's start with the first category. The first type of medication is benzodiazepines. These are drugs prescribed for anxiety and sleep, and they include medications that many of you will recognize by name. Diazepam, lorazepam, alprazolam, and clonazepam are among the most commonly used. These medications have been around for decades. They were considered a major advancement when they first appeared, and for many years they were handed out with very little discussion about what long-term use could mean, especially for older adults. What benzodiazepines do is slow down the central nervous system. They calm anxiety. They reduce the mental noise that keeps people awake at night. They work. That is part of the problem, because when something works, people keep using it. And when people keep using it, dependence follows quietly, without drama, without warning. Here is what changes after 70. As we age, our body's ability to break down these compounds becomes significantly slower. The liver processes them less efficiently. The kidneys clear them more gradually. What this means in practical terms is that the drug stays in your system longer than it used to. A dose that your body might have cleared in 8 hours at age 45 may still be circulating in your bloodstream 18 or even 24 hours later at age 75. You wake up the next morning and the medication from the night before has not fully left your system. You feel unsteady, slightly foggy, a little disconnected from where your feet are. That is when falls happen. Falls in adults over 70 are not minor events. A hip fracture in a 74-year-old has a devastating statistical outcome. Studies consistently show that a significant percentage of older adults who suffer a hip fracture never fully return to their previous level of independence. The fall takes seconds. The recovery, if it comes, takes months. And in many cases, the cascade of complications from a single fall, infection, immobility, pneumonia, becomes the beginning of a long decline. I want to tell you about a patient I'll call Margaret. She was 72, sharp, active, still driving, still cooking for her family. She had been taking a low-dose benzodiazepine for anxiety for about 11 years. Her doctor at the time had started her on it during a difficult period in her life, and somehow it had never been revisited. When she came to see me, she mentioned almost as an aside that she had tripped twice in the past year. Once in the kitchen, once on the stairs. Both times she caught herself. Both times she told herself it was just clumsiness. We reviewed her medications. We worked with her primary physician to begin a very slow, carefully managed taper. 3 months later, She told me she felt more alert than she had in years. She said it was like someone had turned the lights up slightly in every room she walked into. She had not realized how much of her baseline fog was the medication, not her age. Are you or someone you love currently taking one of these medications for sleep or anxiety? If so, I want you to hold that question. We'll come back to it at the end. The second category is strong prescription sleep aids. This is related to benzodiazepines, but distinct enough to deserve its own conversation. I'm talking primarily about what are commonly called the Z drugs: zolpidem, Zaleplon, and esopiclone. These were developed as a supposedly safer alternative to benzodiazepines for sleep. And in some ways, for some populations, that is partially true. But for adults over 70, the picture is considerably more complicated. The reason these medications are concerning is similar to what we just discussed, but with some additional risks that are specific to this class. Zolpidem in particular has been associated with a phenomenon that many patients and families find alarming when they first hear about it: complex sleep behaviors. These are episodes where a person gets up during the night while still under the influence of the medication and performs activities without any awareness or memory of doing so. Walking, eating, in some documented cases, driving. The person wakes up the next morning with no recollection. Even setting aside those more dramatic events, the routine effects of these medications on an older brain are reason enough for caution. Confusion during the night. Disorientation when getting up to use the bathroom. Poor balance in the dark. These are the conditions that lead directly to the falls we talked about with benzodiazepines. There is also something important to understand about how sleep itself changes with age. After 70, it is completely normal for sleep patterns to shift. Going to sleep earlier, waking earlier, experiencing lighter sleep with more awakenings during the night. These are not signs of a disorder. They are signs of a normally aging body. But because they feel frustrating and unfamiliar, many older adults seek medication to restore the sleep they remember having at 45. And the medication addresses the symptom without acknowledging that the symptom was not a disease in the first place. I've spoken with families who didn't realize their parent or grandparent had been on a sleep aid continuously for 4 or 5 years. The original prescription was for 2 weeks during a stressful period. Somewhere along the way, it became a refill that nobody questioned. This happens constantly, not because doctors are negligent, but because short appointments and long patient histories make it easy for medications to become invisible. The next category is where we move from prescription to over-the-counter. And the shift matters because the psychology changes entirely. When a doctor prescribes something, most people at least have a conversation. They receive some kind of guidance. When you buy something at the pharmacy without a prescription, there is very often no conversation at all, just a purchase and a label. The third type of medication I want to discuss is nonsteroidal anti-inflammatory drugs, commonly called NSAIDs. These include ibuprofen and naproxen, both of which are widely available without a prescription. Many older adults use them regularly for joint pain, arthritis, back pain, and general aches. They work reasonably well in the short term, and because they work, and because they're available without a prescription, the assumption becomes that they must be safe. For adults under 65 in good health, short-term NSAID use is generally considered acceptable. For adults over 70, the risk profile shifts substantially. Let me explain exactly why. The kidneys. As we age, kidney function naturally declines. This is not a disease. It is a normal part of aging. But it means that older kidneys are less resilient, less capable of handling the additional stress that NSAIDs place on them. These medications work in part by affecting a group of compounds called prostaglandins, which among other things help regulate blood flow to the kidneys. When NSAIDs suppress prostaglandins, kidney blood flow can decrease. In a young person with fully functioning kidneys, this is temporary and handled without difficulty. In a 75-year-old with already reduced kidney reserve, this reduction in blood flow can trigger acute kidney injury. Acute kidney injury in older adults is serious. It can develop quickly. The early signs, mild fatigue, reduced urination, slight swelling in the legs and feet, are easy to miss or attribute to something else. By the time it becomes obvious that something is wrong, significant damage may already have occurred. NSAIDs also increase the risk of gastrointestinal bleeding. The same prostaglandin system that protects kidney function also maintains the protective lining of the stomach. When NSAIDs suppress that system, the stomach lining becomes more vulnerable. Ulcers and bleeds can develop. In older adults, gastrointestinal bleeding is particularly dangerous because the signs can be subtle, because older bodies often have less reserve to handle blood loss, and because many older adults are also taking blood thinners, which compounds the risk dramatically. And then there is the cardiovascular component. Prolonged NSAID use has been associated with elevated blood pressure and an increased risk of heart attack and stroke in older patients. Given that cardiovascular disease is already among the leading health concerns for adults over 70, adding this layer of risk through a medication purchased casually at the pharmacy represents a significant concern. Imagine this. A 71-year-old man has been taking ibuprofen almost daily for about 2 years because of knee arthritis. He doesn't mention it to his doctor because it's over the counter and he assumes it doesn't count as a real medication. His kidney function, checked at his last annual visit, comes back slightly reduced. Nobody connects it to the ibuprofen. 6 months later, after a bad week of pain where he increased his dose, he ends up in the emergency room with acute kidney injury. He is hospitalized for 4 days. When the medical team reviews his medication history, the ibuprofen is right there. It had been hiding in plain sight. This scenario plays out in hospitals with startling regularity. Now the fourth category, and I want to be honest with you. This is the one where I see the most widespread, underappreciated damage in older patients. Not because it's the most dangerous in isolation, but because it is everywhere. It is invisible, and almost nobody is talking about it in the right way. The fourth type of medication is anticholinergic drugs. If you haven't heard this term before, I'm not surprised. Most patients haven't. But once you understand what these medications do and where they show up, you will start seeing them everywhere. Anticholinergic drugs work by blocking a neurotransmitter called acetylcholine. Acetylcholine plays a critical role in many of the body's functions, including muscle movement, digestion, urination, and, crucially, memory and cognitive function. When these drugs block acetylcholine, they can help with the conditions they're prescribed for, but they do so at a cost that becomes increasingly significant as we age. Here is the list of where anticholinergic effects appear. Certain bladder control medications. Many older antihistamines, including diphenhydramine, which is the active ingredient in a significant number of over-the-counter sleep aids. Some antidepressants. Some medications for vertigo and nausea. Certain muscle relaxants. Some antipsychotics. The point is not to memorize this list. The point is to understand that anticholinergic exposure in older adults is cumulative. You might be taking 3 or 4 medications that each carry mild anticholinergic effects. Individually, none of them seems alarming. Together, they create what researchers call anticholinergic burden, and the cumulative effect on an aging brain can be profound. What does high anticholinergic burden look like in real life? It looks like confusion. It looks like memory problems that come on gradually and then seem to plateau and then get worse again. It looks like constipation, urinary retention, dry mouth, blurred vision. It looks like what we often call brain fog. And here is the part that I find most troubling. In older adults, these symptoms are frequently misattributed. The family notices that grandma seems more forgetful lately. The doctor orders cognitive testing. The pattern looks like early dementia. A diagnosis is made or strongly suspected. Nobody goes back to look at the medication list. There is a growing body of research suggesting that cumulative anticholinergic drug use is associated not just with temporary cognitive impairment, but with an increased long-term risk of dementia. The research is still evolving and not every study reaches the same conclusions. But the signal is consistent enough that the American Geriatric Society and many geriatric specialists consider anticholinergic minimization in older adults to be a genuine clinical priority. I want to share something with you. I had a patient, a woman in her late 70s who her family brought in because they were concerned about her memory. She had been using an over-the-counter sleep aid almost every night for about 3 years. She had also been prescribed a bladder control medication about 18 months prior. And she was on an older antihistamine for seasonal allergies. Separately, each of these seemed reasonable. Together, her anticholinergic burden was substantial. We worked with her care team to eliminate the over-the-counter sleep aid entirely, find an alternative for the allergy management, and discuss with her urologist whether a lower-risk option existed for the bladder symptoms. Within about 2 months, her family said she seemed noticeably sharper. The memory concerns had not entirely resolved, but the speed of the decline had slowed visibly. I want to ask you directly, do you or someone you love take an over-the-counter sleep aid regularly? Does it have diphenhydramine on the label? That is an anticholinergic drug, and if the person taking it is over 70, I would strongly encourage a conversation with their physician before the next dose. The fifth category brings us back to over-the-counter territory, and it is one that surprises many people because it involves a medication that has a strong, positive reputation built over generations. The fifth type of medication is certain common pain relievers that interact badly with the aging cardiovascular and kidney systems when used in excess. I'm speaking specifically about medications like aspirin used in higher doses beyond the low-dose cardiovascular context, as well as combinations of over-the-counter pain and cold medications that contain multiple active ingredients. Let me explain the combination issue first, because it is less understood. Walk into any pharmacy and look at the cold and flu aisle. You will find products that combine a pain reliever, a decongestant, an antihistamine, and a cough suppressant into a single tablet. For a younger person dealing with a cold, these combinations are convenient. For a person over 70, they are a layered set of risks compressed into one pill. The decongestant can raise blood pressure significantly. The antihistamine almost certainly has anticholinergic properties. The combination as a whole is something that an aging body, especially one already taking multiple prescription medications, may handle very poorly. There is a specific concept I want to introduce here called polypharmacy. This is the clinical term for taking 5 or more medications simultaneously, and it is extremely common in adults over 70. Research consistently shows that the risk of adverse drug interactions increases dramatically as the number of medications increases. The problem is not just individual drugs. It is the combinations. Drug A might be fine. Drug B might be fine. Drug C might be fine. But drug A plus drug B plus drug C, especially when processed by a liver and kidneys that are already working at reduced capacity, can create effects that nobody predicted and that look nothing like what any individual drug would produce on its own. The over-the-counter medications that seem harmless become unpredictable ingredients in this combination. And because patients often don't mention them to their doctors, because they don't seem like real medications, the physician never has the complete picture. I had an elderly gentleman, 78 years old, come in following a concerning episode where he had become significantly confused and disoriented. He was on blood pressure medication, a statin, a mild diuretic, and a prescription sleep aid. His family had not mentioned, and he had not thought to mention, that he had been taking an over-the-counter cold medication for about a week. The combination of the decongestant and the cold medication with his blood pressure drug, plus the antihistamine interacting with his sleep aid, had created a level of sedation and blood pressure fluctuation that his body could not compensate for. He recovered fully, but the experience shook his family, and it shook him. None of this happened because of negligence. It happened because of a knowledge gap. And that is what I am trying to close today. Now let's talk about what to do. Because information without action is just anxiety with a better vocabulary. What I tell families before they continue these medications comes down to a small number of clear, practical steps. These are not dramatic interventions. They are conversations, reviews, and habits, and they can make an enormous difference. The first step is a complete medication review. This means every medication, including over-the-counter drugs, supplements, vitamins, and anything purchased at the pharmacy without a prescription. Write them all down. The name, the dose, how often it's taken, and how long it has been taken. Bring that list to the next doctor's appointment. Not just the prescription bottle list. Everything. This sounds simple. In practice, a surprising number of adults over 70 have never had this comprehensive a conversation with their physician. Their prescription medications are tracked. Their over-the-counter habits are invisible. The second step is to ask a specific question. Not a general question like, is this medication safe? Ask this. Given my age and my kidney function, is this medication still the right choice? That question signals to your doctor that you understand the age-related changes we discussed. It invites a real answer rather than a reflexive reassurance. The third step is to ask about deprescribing. Deprescribing is the clinical practice of systematically reviewing and reducing medications that may no longer be appropriate. It is a legitimate, evidence-based area of medicine, and many physicians who specialize in geriatrics are experienced with it. The goal is not to remove all medications. Many medications are absolutely essential. The goal is to remove medications that are no longer earning their place given the current risk profile. The fourth step is to pay attention to the warning signs we discussed. If someone over 70 in your life is showing new or increasing confusion, if they have had an unexplained fall, if they seem more fatigued than usual, if their memory seems to have declined recently, do not automatically assume it is simply aging. Consider whether a medication review is warranted. These symptoms are reversible in a meaningful number of cases when the underlying cause is a medication interaction or accumulation. The fifth step is to resist the urgency to find an immediate replacement for every medication that gets identified as potentially problematic. This is a gradual process. Stopping a benzodiazepine abruptly, for example, can be genuinely dangerous. Any changes to long-term medications need to happen slowly, with medical supervision and with a plan. The goal is not speed. The goal is safety. The sixth step involves pharmacists. This resource is dramatically underused. Pharmacists are specifically trained in drug interactions and medication appropriateness. Many pharmacies offer medication review services, and your pharmacist can flag interactions and concerns that your physician may not have noticed simply because the physician didn't have the complete picture. Don't walk past your pharmacist. Talk to them. The seventh and final step is to share this information, not to frighten anyone, but because so many families are navigating these exact questions right now without the vocabulary to ask the right questions. If your parent or grandparent or sibling or close friend is over 70 and taking multiple medications, a gentle conversation, a request for a medication review, a single specific question asked at the next appointment could meaningfully change the trajectory of their health. I want to close with something that I feel strongly about. The goal of everything I've shared today is not to create fear around medications. Medications save lives. They manage chronic conditions that, without treatment, would cause real suffering. They allow people to live with heart disease, diabetes, high blood pressure, anxiety, pain, and depression with a quality of life that would not otherwise be possible. I am not asking you to distrust medicine. What I am asking is for a specific kind of vigilance that is appropriate to the stage of life we're discussing. A 70-year-old body is not a 45-year-old body. It has different needs, different vulnerabilities, and a different relationship with the medications it takes. Recognizing that is not defeat. It is wisdom. The 5 categories we covered today, benzodiazepines, prescription sleep aids, NSAIDs, anticholinergic medications, and over-the-counter combinations, represent some of the most common sources of preventable harm in older adults. Not because the medications are evil, because they are often continued beyond the point where the benefit still outweighs the risk. That calculation deserves to be revisited regularly with a physician who has the complete picture. If your doctor is dismissive of these concerns, ask for a referral to a geriatric specialist. Geriatricians, doctors who specialize in the care of older adults, are trained specifically to think about medications through this lens. Their perspective is often different from a general practitioner simply because this is the population they spend all of their time with. You deserve a physician who takes these questions seriously. You deserve a medical team that looks at the full picture. And the first step toward that is exactly what you did today. You asked the question. If this video gave you something useful, I'd encourage you to share it with someone who needs it. An older parent, a sibling, a friend who mentioned that their mother has been having more falls lately. These conversations start somewhere. They might as well start here. I'm Dr. Adrian Cole. Thank you for watching, and I'll see you in the next video.